Good afternoon, everyone, and welcome to this AHA Hypertension webinar. Today, we have a couple of guest speakers that have agreed to speak on primary aldosteronism screening and interpretation. I'd like to welcome Dr. Adina Turcu, who's an endocrinologist at University of Michigan, and Anand Vaidya, who's an endocrinologist at the Brigham and Women's Hospital. I'll be moderating. My name is Matt Luther. I'm a hypertension specialist and nephrologist at Vanderbilt. We also will have a couple of panelists to discuss the case later on at the end of the hour. Jordana Cohen at University of Pennsylvania, who's a nephrologist and hypertension specialist, and Vivek Bhalla, who's a nephrologist and hypertension specialist at Stanford, will join. We also have Steve Crowley, who's going to moderate the chat. And if you do have questions that come up that you'd like us to elevate and bring to the attention of the discussants, please put that in the chat and we'll be monitoring that throughout. So with that, I'll let Dr. Turcu take over. Thank you.
Thank you for the introduction, Matt, and many thanks for having me part of this initiative to increase awareness and hopefully also clarity on PA screening. I have one disclosure which is not related with our topic today. I mean, with the topic, but not be discussed in today's conversation. So I wanted to start off with a case, and I invite the audience to think about this case. We'll come back to it later in the session, and I hope we will have the opportunity to discuss a few points along this case with the expert panelists. So it's a 77-year-old man. He has a history of hypertension, at least since the 1980s, maybe longer. He also has sleep apnea, coronary artery disease, and he had prostate cancer, which was successfully treated with just prostatectomy some years ago. His blood pressure is high, despite having taking, or at least being prescribed 4 blood pressure medications. You see them listed here: lisinopril, amlodipine, metoprolol, and spironolactone. And so the first question I'd like to pose to the audience to consider is, would you screen this patient for PA? And here you have your options, yes, no, or depending on how busy you are in your clinic. And say for those of you who would consider screening, you get these labs back. So a little bit of hypokalemia, 3.3. And here you have an aldosterone of 12 nanograms per deciliter and a renin of 3.2 picograms per ml. So question to you all, and then to the panelists later, is if this PA screening test is positive, negative, or unsure, you're uncertain about the results. So with this in mind, I'll get going with the points we want to touch on today. First is to emphasize the clinical relevance of PA. Why should we bother looking for this entity? Second, to define in a way what is the target population for PA screening. And then Dr. Vaidya will talk about PA screening test interpretation and limitations. So first off, do we need any aldosterone at all? And if so, what are the circumstances we need it? So aldosterone and then the preceding renin-angiotensin system components come in handy anytime we are at risk for dehydration. So anytime we have a sodium and fluid deficit, or in case of aldosterone, also a potassium surplus. And examples include many illnesses that predispose to dehydration, with high fever, diarrhea, vomiting, blood loss of any kind, or even physiologic perspiration that is prolonged during intense physical activity, especially if it's under hot and humid conditions. So the RAS is particularly instrumental in such situations if we don't have immediate access to salt repletion. And this was the case for most of our history on this earth. Up until about the Industrial Revolution, this only happened 2 to 3 centuries ago. And today, actually, as a result of overzealous use of salt, 9 in 10 US individuals as early as age 2 consume maybe 5, 10 or more fold more sodium than it's recommended. And this amount is easily achieved with any small snack that you can buy in a gas station or in any cafeteria across the United States. So on a regular Western diet, the renin-angiotensin system really becomes obsolete, and it should be completely turned off. And this should be the case for most of our lives. Now in PA, renin is indeed suppressed, but aldosterone production is dysregulated, and it becomes really difficult to suppress with physiological stimuli. And this leads to a vicious retention of salt, intravascular volume expansion beyond capacity, and that leads to hypertension. And in exchange for sodium, the kidney excretes potassium and hydrogen ions, and with this comes a risk of hypokalemia and non-ion gap acidosis. And all of these features can indeed be seen in the very extreme PA phenotype. This was illustrated by this index case described at University of Michigan almost 60 years ago by Jerome Kahn. This woman presented in her 30s, but indeed he had hypertension at least since her 20s and had severe high blood pressure, common readings in the 200 systolic, 100 and higher diastolic. This is a hallmark of PA, really high diastolic blood pressure. She also had hypokalemia, which was profound and symptomatic, with episodic muscle spasm and weakness. Now, if you think about the patients you have in your clinic today, often they don't really have any distinctive features that might clue you towards primary aldo. Often they have resistant hypertension, but also have other comorbidities that predispose to high blood pressure, including obesity and sleep apnea, diabetes, and so forth. Often they take many blood pressure medications. And no surprise, many of these patients have normal potassium because by the time we think about this entity, they have chronic kidney insufficiency, which predisposes to hyperkalemia. And many of these patients, especially if they also have diabetes or early CKD, they take an ACE inhibitor or an ARB. So there is really a lot more to hypertension, to primary aldo than just high blood pressure. And so if we have this inappropriate activation of MR by aldosterone in the context of high salt, there is end organ damage, particularly to the heart and the kidney, with predisposition to inflammation and fibrosis, enhancement of the oxidative stress, endothelial dysfunction, and even metabolic features of insulin resistance. With this, patients with PA then gain this additive risk of developing stroke and coronary artery disease and atrial fibrillation, LVH, and again, some metabolic features, diabetes, insulin resistance. This is an excess risk beyond that posed by primary hypertension. So despite correcting for the equivalent hypertension that patients with high blood pressure already gain. Another study here from Anand Vaidya's group showed not only that patients with primary aldo have this excess risk for cardiovascular events, but also for death. This again is after you adjust for other risk factors of mortality. So the good news is that targeted therapy for PA, either with curative surgery or with appropriate medical management, can abrogate the excess cardiovascular and renal risk to the background risk of patients with primary hypertension. So in itself, this opportunity to circumvent the risk for serious comorbidities becomes an argument to identify and treat primary aldosteronism early on. A second argument is the scale of PA prevalence, especially that is never identified. So if you look in the US, almost 1 in 2 adults has hypertension, which sums up to about 120 million people. And of those, about 75% have hypertension that is not under control. And you might think, well, in this medical and technological era, how come we have incredibly high rates of poorly controlled hypertension? And this is not only disappointing, but hardly conceivable that it's possible. And in part, this is due to this pervasive one-size-fits-all approach to hypertension therapy with really modest efforts to personalize treatment for patients with hypertension. And this approach, in turn, has been driven by this traditional teaching in school that under 5 to 10% of patients with hypertension might have underlying remediable causes, but probably most everybody has what we call essential or idiopathic hypertension. However, when we look rigorously, we find secondary hypertension in a considerable amount of patients. This is one study illustrating that secondary hypertension might be found in as many as 40% of the patients if you test. These are all comers, both new onset and established hypertension. Everybody was offered secondary hypertension testing. And what you see is that primary aldo came second only to sleep apnea for about 27% of secondary hypertension cases. You see it both along with sleep apnea here in the pink slice, and then the majority of the endocrine hypertension cases. So in total, about 27%. Now, across the hypertension spectrum, the prevalence of PA increases with the severity of hypertension. We have about 10 to 15% PA detection among patients with early stages hypertension, and about a quarter of those with treatment-resistant hypertension. Another population at risk for PA includes patients with high blood pressure and hypokalemia, and the more profound the hypokalemia, the higher of risk of PA. PA has also been linked with sleep apnea. This is a bidirectional relationship. And so some, but not all studies suggest that the prevalence of PA is higher among patients who have sleep apnea, particularly in men. And similarly, there is this dual relationship between primary aldo and atrial fibrillation. The prevalence of PA appears to be much higher among those with atrial fibrillation and stroke. Okay, so with these data in mind, question is, who should we screen for primary aldo among the large pool of patients with hypertension? And we have some guidance from large expert panels. One here on the left is the ACC in conjunction with the American Heart Association, and then on your right, you have the endocrine society guidelines. The latter refers specifically to PA, while the ACC-AHA guidelines refer just broadly to anybody who might be at risk for secondary hypertension. And the common ground between the two is patients with severe resistant hypertension, or those who suddenly have difficult to control hypertension after a period of manageable control. Some other variable indications include early onset hypertension or very late onset hypertension. Hypokalemia, here there is a discrepancy between ACC-AHA guidelines offering screening only if you have unprovoked or excessive hypokalemia, while the endo guidelines suggest we should screen for PA, not only in those with diuretic induced, but also if you have spontaneous hypokalemia. So, if you think about PA, we have learned a lot in the past years, and we know that the pace of progression is rather slow, not rapid, but we probably see this early end organ damage early in the stage of the disease. So question is, at what stage of hypertension should we screen for primary aldo? And so the old school teaching, as you saw in those expert guidelines, is to only test for PA when patients have difficult to treat late stage hypertension. However, many experts now are shifting this thinking and propose introducing PA screening earlier in the stage of hypertension, as soon as sometimes when hypertension is diagnosed, which offers some advantages. For instance, no interfering medications, which we will talk about a little later. In the meantime, however, we know that even with the most conservative PA screening recommendations, the uptake of these recommendations is a meager 2% or less. And many studies demonstrate this consistently. I'm just going to show a few. This is a populational study across the US VA system, patients with resistant hypertension study of Dr. Cohen here, 1.6% of patients, candidates were screened. Another study, populational study, hypertension and hypokalemia, coming from Ontario, Canada, again, barely under 2% of patients at risk were screened. What was disappointing to us was that only 3.4% of patients across all major indications at University of Michigan were screened. And this was particularly disheartening because we have this rich legacy of PA, and we have some of the best resources for both PA testing and therapy in the US at U of M. So definitely we're not doing any better than other places. Bottom line here is PA is common. PA is a serious health threat, yet it is rarely considered. And then when it is, it's barely in patients at the highest risk with the highest index of suspicion, and often after irreversible health complications have developed. Why is that? We don't have time for a lengthy discussion today, but among culprits is the overwhelming volume of patients with hypertension, the lack of distinctive features of PA in the common patient with PA, and also the complexity of testing and interpretation, which Dr. Vaidya will illustrate next.
All right, thank you so much, Adina, and thank you to the organizers for having me here today. It's a pleasure to be here. Here are my disclosures. I will start off with a case as well. This is a 64-year-old woman who presents for hypertension management. At age 31, she had her first pregnancy. She developed gestational hypertension. At age 33, she had a second pregnancy. She again developed gestational hypertension, this time complicated by preeclampsia. At age 35, she had a third pregnancy. This time she actually had pre-gestational and untreated hypertension and was complicated by eclampsia. It's only after this pregnancy that she was diagnosed with hypertension and started on a thiazide and an ACE inhibitor. And then 20 more years passed, during which time her blood pressure worsened. Her blood pressure is in the 150s over 160s, 150 to 160s over 100. She's had multiple episodes of hypokalemia. And finally, at age 60, she's tested for primary aldosteronism for the first time, while on a thiazide and while on an ACE inhibitor. Her plasma aldosterone concentration measured by a mass spec assay was 8 nanograms per deciliter, and the renin was undetectable. The potassium was 3.7. And you can think about how you would interpret these values, but what I'll tell you is this person who ordered them thought that these values excluded primary aldosteronism, namely because the aldosterone value was low or not high enough. And so more years passed, then she was evaluated by a hypertension specialist who tested her for her second time, also on a thiazide and an ACE inhibitor. And the testing results were quite similar. The plasma aldosterone by a mass spec assay was 8.8 nanograms per deciliter. The renin was undetectable, and the potassium at this time was normal at 3.9. And again, you can consider how you would have handled this, and we can discuss this openly afterwards. But these testing results were also considered to exclude the diagnosis, mainly because the aldosterone values were not high. She then saw a third specialist a year later who did an oral sodium suppression test. So this person actually suspected primary aldosteronism and then tried to, quote, confirm it. So here the 24-hour urinary sodium excretion is high. It's like 4 or 5 grams of sodium a day. And in this context, the 24-hour urinary aldosterone is 9.3 micrograms. And this specialist then was confused because the official cutoff for a positive oral sodium suppression test is 12, and sometimes more liberally 10. And this is even below that liberal cutoff. And so they contemplated excluding the diagnosis, but several interventions happened, and she was diagnosed with primary aldosteronism and was one of the unfortunate in some ways, as you can see through the chronology of this case, but fortunate in that she ultimately was diagnosed with lateralizing primary aldosteronism that was then treated with an adrenalectomy. And so this case actually highlights many of the points on delayed diagnosis, under testing that Dr. Turcu mentioned, and then some additional cases, discussion points on interpretation of testing that we'll talk about here. So I'll pick up where Adina left off and focus on how do we recognize primary aldosteronism better, how do we test and interpret that testing. So the key questions here are: what is primary aldosteronism? What is a high aldosterone level? Does primary aldosteronism need to be confirmed? And then how can we put all of this together to maximize diagnosis and treatment, which I think we can openly discuss as a panel. So the fundamental question to me is, what is primary aldosteronism? And I think Adina started to describe this as a syndrome of pathophysiology. And that syndrome is really characterized by inappropriate aldosterone production. So this is non-physiologic aldosterone in that it's non-suppressible, it's being produced independent of renin and angiotensin II. And it's this pathophysiology that results in excessive mineralocorticoid receptor activation, a vicious cycle of volume expansion that can then cause deleterious cardiovascular and kidney disease, independent of blood pressure. The hallmark biochemical diagnostics are then a suppression of renin, but in the context of this renin suppression, some degree of inappropriate or dysregulated aldosterone production. And really how you interpret or operationalize what's written here in red will determine how much and how frequently you will diagnose primary aldosteronism. And as was mentioned, most patients with primary aldosteronism have neither resistant hypertension or hypokalemia. They certainly can, but you do not need to have either of these cardinal features to be diagnosed. So one, I think, slowly gaining momentum truth, but sometimes still controversial, is the landscape of primary aldosteronism testing is dominated by relatively arbitrary and unnecessarily complex practices that rely on unvalidated diagnostic thresholds. This is a kind of a mouthful of words, but to me, this is the crux of the problem that exists today that makes primary aldosteronism testing very challenging and the core of what needs to be simplified and where education needs to be focused on. So what do I mean by that? So this is the classical, what I would call two-step approach that almost every guideline in the world recommends. So this approach first involves identifying an at-risk population. As Adina mentioned, there's already a big bottleneck there. Fewer than 2-3% of people are ever identified. But when they're identified, the first step is to measure an aldosterone and a renin, then look at the aldosterone to renin ratio or look at the aldosterone, and then determine whether it's high or positive. And this determination is relatively arbitrary. Okay, so depending on which units you use, it's some round number. You know, in our units, mostly in the United States, it's something like 10, 15, 20, 25, 30, some round number that you have to be higher than. And these are not strictly validated. Okay, so there's a lot of variability in how people interpret what's a positive screen for primary aldosteronism. If you pass this test or bottleneck, you then have to go to a second step. And almost every guideline in the world recommends performing a confirmatory test for the explicit reason to either confirm or exclude the diagnosis. Now, this confirmatory test exists in multiple forms. There's at least 10 protocols that I'm aware of, and each one of those protocols, dynamic protocols, has its own threshold or categorization on what constitutes it being positive or negative. And then if you pass this bottleneck, you're diagnosed with primary aldosteronism. So you can see how much variability there is and how much room for differences of opinions there are in this classical two-step approach. So what leads to erroneous exclusion of primary aldosteronism or misdiagnosis or underdiagnosis, as you saw this patient in the clinical vignette underwent? And I think there's three general large reasons. The first is there is no reference or gold standard diagnostic. We don't have an international consensus on how to define primary aldosteronism. And as a result, the diagnostic thresholds that I just showed you are somewhat arbitrary. They're not calibrated to one another, and they're not rigorously validated, in some cases, not validated at all. And that is really what drives a lot of the variable practices across the world. Even in our own institution, we have variable practices. Another reason the diagnosis is often missed is an underappreciation for the variability of aldosterone production. So aldosterone is a hormone, and like almost every other hormone you're aware of, its production is variable throughout the day. Just like cortisol or insulin or growth hormone, it's not produced in a static manner. Here's an illustration of that, and this has been shown in many studies. On the x-axis are about 50 patients who have confirmed primary aldosteronism. In the black dots are their plasma aldosterone values measured on different days. And in red is the average of their aldosterone values on different days. And they're just ordered from lowest to highest. And so what you can appreciate is that there's tremendous inter-individual variability. Okay, even though they all have primary aldosteronism, some on average have much higher and some have much lower mean aldosterone values. But further, there's tremendous intra-individual variability. The same patient on a different day could have a dramatically different aldosterone value. Okay. Another way to summarize this is that even though all these patients had primary aldosteronism, on any given day, something like 30 to 50% had at least one aldosterone value below 10 or 15 nanograms per deciliter. And on any given day, any one of these individuals had an aldosterone to renin ratio below 20 or 30. This occurred 25 to 60% of the time. I'm just showing you this so you can see that if you used any of these thresholds to rule in or rule out primary aldosteronism, particularly exclude the possibility of primary aldosteronism, you would have erroneously missed these cases, a large fraction of them on a particular day. Another reason that often causes confusion is an underappreciation for modern aldosterone assays. So for decades, aldosterone and other steroids were measured via immunoassay, and then more modern immunoassays, and now more and more, particularly at large reference labs, certainly in the United States, it's being measured by liquid chromatography, mass spectroscopy, which is a fantastic tool. It's highly accurate, reproducible, high throughput. However, it doesn't pick up cross-reacting steroids like immunoassays would, and as a result, mass spec values of aldosterone as well as other steroids will often and almost always be lower than the immunoassay correlate. How much lower? It depends on the particular immunoassay, but up to 30 to 60% lower, which is a lot. So in other words, if you measure an aldosterone in the same blood tube by immunoassay or mass spec, the mass spec aldosterone value and correlating aldosterone to renin ratio will be a lot lower. In other words, if you use certain thresholds to designate the possibility of primary aldosterone as a yes or no, you need to now either completely recalibrate those thresholds for modern mass spec assays, if that's what your lab runs, or throw out the idea of categorical thresholds, which is another possibility. And finally, I think another problem that you saw in this clinical vignette that can result in erroneous exclusion of primary aldosteronism is an over-reliance on confirmatory testing. I don't particularly like this term confirmatory. I think it has a huge psychological implication. When you use the word confirmatory, you think the test you're doing will help you rule in or rule out primary aldosteronism. But these tests are not validated to do that. So I think a better terminology is aldosterone suppression test. These are dynamic maneuvers designed to suppress aldosterone. This is a much better descriptor. Now, whether you can use the results of that dynamic maneuver to rule in or rule out aldosterone is a separate discussion. So here's the problem with confirmatory tests. Okay, let's put aside the relatively arbitrary traditional diagnostic thresholds. Let's ask a more fundamental question, which is, how common is inappropriate, non-suppressible renin and angiotensin II independent aldosterone production? Which is to say, how common is primary aldosteronism pathophysiology? And what you can do to interrogate this is do an aldosterone suppression test. Try to turn aldosterone production off, and then quantify the spectrum of this pathophysiology, agnostic of the traditional thresholds and the pedagogical approach that has been recommended for years. And I'll show you one example of that using the oral sodium suppression test. I'm not here to endorse this particular aldosterone suppression test. There are many, but whether you do it this way or with another one, you will see similar results. So this maneuver has been used for 5 to 6 decades because it's designed to turn aldosterone off. So it relies on the fact that most of your patients are consuming a high sodium diet. In the United States, it's somewhere between 3 to 4 grams a day, which is already enough to conduct this test. But to ensure that the test is valid, you supplement with more sodium. So 2, 3, 4 grams extra per day for 3 or 4 days. Your patient will get thirsty to defend their osmolality, and they will drink water. So the net effect after several days is that your patient will be on a high sodium balance and drinking a lot of water. So in other words, this is a method of oral saline loading. So this oral saline loading test is performed so that you expand extracellular and intravascular volume. You induce an appropriate or physiologic suppression of renin and angiotensin II. And in this context, which is sodium loading, volume expansion, renin and angiotensin II suppression, aldosterone should be maximally suppressed. And any aldosterone that is not suppressed is some shade of primary aldosteronism pathophysiology. So in this study, this test was performed on individuals that represented the whole blood pressure continuum. So this is individuals with resistant hypertension, stage 1, stage 2 hypertension, even people with normal blood pressure. And these are the main results. So here on the x-axis are the individual participants who have completed an oral sodium suppression test, are in a high sodium balance, have a suppressed renin and angiotensin II. And what you want to see is, did they turn aldosterone production off? Which is quantified here on the y-axis as the 24-hour urinary aldosterone excretion rate, reflecting the magnitude of primary aldosteronism. And what you see is this. Each one of these blue vertical lines is an individual participant. They're ordered from lowest to highest. And what you're looking at is a severity spectrum of non-suppressible renin-independent aldosterone production. In other words, a continuum of primary aldosteronism pathophysiology. So here on the left, this is physiologic, right? This is what you expected. These individuals turned aldosterone production off. And here on the right is the opposite. These individuals have overt pathophysiology. They clearly have primary aldosteronism and can't turn aldosterone production off at all, despite this maneuver. I think that's the easy part. What's difficult is everything in the middle, right? So you have a continuum here, and you have to answer, when does physiology end and when does pathophysiology begin? And I think the challenge with this question that I think confounds many people is that you do not see on this continuum a clear biological inflection point where you can depict the beginning of primary aldosteronism or the end of primary aldosteronism. I think if you wanted to be objective, you could say that when you're volume loaded and sodium loaded, any aldosterone production in the context of renin suppression might represent a continuum of primary aldosteronism pathophysiology. But we are not taught to use this continuous construct. We're actually taught to categorize this. The official threshold for a positive oral sodium suppression test is 12. And this has been the case for 50, 60 years. And it's not validated on any gold standard. It's, I think, made up or entirely arbitrary. And you can see the problem with that. This line bisects this distribution. And if you use it strictly, it implies that everyone over this line has primary aldosteronism. And it also implies that everyone below this line does not have primary aldosteronism. But the reason I like to show this raw data is you can see with your own eyes that the people below this line have the same phenomenon as the people above this line, just of a milder magnitude. If I showed you the same data separated by or stratified by clinical phenotype, blood pressure phenotype, you see that this continuum exists in every blood pressure phenotype, except the magnitude of primary aldosteronism pathophysiology generally parallels the magnitude of the blood pressure phenotype with great heterogeneity. And if you were to strictly apply this arbitrary threshold of 12, you could create a prevalence estimate. Okay, you could say that 9% of normotensives, 15 to 20% of hypertensives, a quarter of resistant hypertensives meet the criteria for overt primary aldosteronism. But what I want to emphasize here are not the individual prevalence estimates, okay, because you can completely change these by simply changing the definition of what an oral sodium suppression test threshold is. You can make it higher or lower. If you use the continuous construct, you would find that these numbers are a lot higher. And if you use an arbitrary categorical construct that's more conservative, you could make these numbers lower. And as I mentioned earlier, if you repeat everything I just said with saline suppression testing, which some of you use, or captopril challenge testing, which some of you use, you'll see the same continuum that ranges from physiologic suppression to overt pathophysiology and a full continuum in the middle that has no discrete cutoffs for diagnosing primary aldosteronism. And it's in this light that several studies have started to come out and raise awareness about the value of confirmatory testing. So here's two recent meta-analyses that highlight that the evidence behind using these aldosterone suppression tests to confirm or exclude primary aldosteronism is very low and in some cases non-existent. If you use these types of tests frequently, you're going to more likely exclude true cases of primary aldosteronism more so than confirm true cases. Another way of wording this is that if you do an aldosterone suppression test and then you interpret its result as a positive confirmation, it reaffirms what you should have already suspected from your screening test. However, if you do an aldosterone suppression test and you interpret the result as negative, this is not a reliable method to exclude the possibility of primary aldosteronism, and you put yourself at risk of excluding true cases of primary aldosteronism. You saw the patient in the clinical vignette be at risk of that. So maybe I'll stop here. I think we have several panelists and discussion items to talk about, and if we want, we can talk about how to operationalize all of this in a diagnostic algorithm, but it may come up in the question and answer and discussion with the panelists. So I will stop sharing my screen here and open it up for discussion.
All right, thank you both. I think that's a great introduction to hopefully a discussion of the issues. Both of you presented cases that are classically not defined by the cutoffs that you've defined. In particular, the aldosterone's relatively low. I should also point out that Adina, I believe, presented a renin mass assay, and Anand presented a plasma renin activity result. And so I think a lot of the hesitation for interpreting or even sending aldo-renin ratio may be due to not some of the PCPs or physicians not being familiar with the test, not being confident in interpreting the results like you've discussed already. So my question for the panel, so Jordy, Vivek, when do you screen? Would you stop the medicines? In particular, Adina's patient was on spironolactone, and yet renin mass, I believe, was still relatively low. How do you interpret that, and what would you do in those cases, Jordy or Vivek?
With the first patient who was on the spironolactone and had a relatively low renin mass, which I'm not even familiar with that assay, and I believe that patient had a normal aldosterone, correct?
So I wrote down the aldosterone was
let me pull it up.
12.
Yes.
Aldosterone
Aldosterone was 12.
Yeah, I
And
think in that
renin
case it
was
was
massive
very
3.4.
hypokalemic. So I think my bigger concern in that situation would be to replete the potassium than to make any changes in medication, because we know this person still has a suppressed renin in the setting of spironolactone. So if this is primary aldosteronism, they're not sufficiently treated yet. So we can interpret that. We would expect that the low potassium level would be suppressing their aldosterone. So I would replete their aldosterone and recheck that to have a
Replete
more of an
potassium.
interpretation.
Mhm.
Replete the potassium, sorry. In the other case, the aldosterone was low and they were on an ACE inhibitor. I tend not to stop the medications. I just try to interpret the results in the context of the medications that they're on. So that would have been a clue to me in the other case, that with such a suppressed renin and an aldo that's just very slightly below threshold, that it's likely due to the ACE inhibitor lowering the aldosterone, and that I would have leaned more towards that being a positive case. I don't know, Vivek, do you have an alternative approach?
Thanks, Ray. I think I'll start with the second case first. I agree very much that I think it's from a practical standpoint, we have to allow testing on medications. Otherwise, testing will be even lower than the 2% or roughly 2% screening tests that both Adina and Anand highlighted. And so I think the way that I would approach that is that the test result, given the arbitrary thresholds that they was sort of just under that arbitrary threshold. And I would take the medications that they're on and basically say that you're biasing towards a false negative with that medication cocktail, and so that you have a lower threshold for considering the diagnosis, and therefore move forward with further testing at that point, just based on that, rather than stopping the medications and retesting. I think if you have a patient that is hesitant about further testing, or further testing is going to be an at-risk procedure with something that's invasive, I think you can have a discussion with the patient very easily and redo testing off medications. But at that point, if we're talking about a more general approach for most patients, I would move forward with the lower diagnostic threshold. And again, that's not based on the guidelines, because the guidelines are both arbitrary and probably false, but it would just be my diagnostic style in that case. Oh, sorry, go ahead.
No, go ahead. I fully agree. I was just going to say it also will depend on the next steps. If the patient is somebody who would be pursuing surgery and I need to do adrenal vein sampling, that's typically when I would consider holding spironolactone, but I would only hold mineralocorticoid receptor antagonists for that. I would not hold anything else. If they're not going to proceed, then I would just initiate testing at that point, again, based off of these results, per Vivek's points that he made, because especially in the first patient who's already on spironolactone, they're just not on a sufficient dose since their renin is still suppressed. And so I would just want to increase their dose. They're tolerating it, and it's something that clearly they would benefit from a higher dose of.
So I think that brings up a great point, and it's in using these labs not only for screening, but also for monitoring treatment. So my comment on this case that's being shown here, I always, when I'm starting spironolactone or going to start spironolactone in somebody I'm medically treating, that's when I would definitely make sure that I have an aldosterone and renin that's been done before I start spironolactone. But I've learned this partly, I believe, from Dr. Vaidya and Adina as Dr. Turcu as well, that I use renin to monitor the response to make sure that I'm adequately treating. So this patient, besides the potassium still being low on spironolactone, the renin activity, or I'm sorry, the renin mass is still a little bit low, and that might suggest that even though he's on a reasonable dose of spironolactone, is not well treated. Let's see, this is Dr. Turcu's case. Can you comment on your interpretation of these results on spironolactone?
Sure. Well, one of the reasons I brought this case on was to just raise awareness about the different renin assays. I just see one attendee who says here that Dr. Funder, who I also see being present on the webinar, has been advocating for a PRA as a first approach, and if that is suppressed, then measure your 24-hour urine for sodium and potassium and aldo. And the number is coded here is less than 1 and without units. So I just wanted to make to bring this difference in the recent shift in renin assays. Many of the labs are transitioning from PRA, based on which the aldo-renin ratio has been developed, and everybody's thinking, oh, it has to be below 1, to direct renin mass, which we know has different units and different numbers, and the conversion is usually derived in every lab when the transition happens. In our lab, that ratio is a PRA to direct renin about 1 to 8 or 1 to 10 roughly, but I've seen it as high as 1 to 14. So I just wanted to confirm that this is indeed a suppressed renin, despite having spironolactone and the lisinopril. So this would be totally a positive screen. Even though aldosterone is not striking, it is above 10, or, you know, if you wanted to use Anand's ratio, threshold 6 or whatever threshold you want to use, despite having low potassium. So we did replete the potassium in this patient in repeated testing. 1 second. So I would vote for positive screen in this case. And after potassium was repleted, let me see if I had this here. I have to advance a few more slides. Okay, so the patient was put on potassium chloride 20 milliequivalents 3 times a day. And to make things cleaner, spironolactone was stopped. Potassium barely reached the lower normal range, and now his aldosterone was 32 with, again, suppressed renin. So much more impressive aldosterone once potassium was normalized.
Can I bring up just one point with this first case, Dr. Turcu? I think it's important for us to realize that although the screening rates are unacceptably low, I think over the last few years, we've all come to appreciate that non-adherence is quite a prevalent condition. And seeing a patient like this in clinic who presents with 50 milligrams a day of spironolactone, who's hypokalemic and has metabolic alkalosis, and a suppressed renin, that we have to consider for the fact that they might not be taking their medications. And I think it just really highlights the fact that spironolactone is one of those medicines that you can probably tell pretty accurately for adherence because of the biochemical changes that it does incur, unless they have a severe case as you're presenting here. But I think for a lot of patients in clinic, one of the first things that I thought of when you showed the case was maybe they're not necessarily taking this spironolactone. The other point of this case that I just wanted to make is this is an older gentleman with obesity who's on spironolactone 50, and assuming that he's taking that medication, you've then gone on to show that he will probably need more, that he's being undertreated. And I do worry about compliance and side effects when you get above that level of spironolactone in a patient like this. And so it may not be as popular to this audience, but one of the things that I would consider doing in a patient like this is putting them on a Clarinone. Not because I think it's more potent, it's a lot less potent, but I think the side effect profile would be a lot more acceptable to a patient such as this going forward, knowing that you're going to have to go up. And you might lose your patient if you advocate to a patient who's had hypertension for 40 years to go up on this one medication and start to have side effects, as opposed to using a different medication to accomplish the same goal, and maybe be able to have a better chance of reaching that goal due to a lack of side effects. So just another point that came up when you presented this case.
Sure. Now, today we didn't focus very much on treatment. This patient ended up having lateralized PA, but let me ask both of you, would you do a confirmatory test in a patient like this with these numbers now? And would you make any other medication changes? We still have some medications that could interfere with a renin and aldo measurements. With these data here, would you go ahead with a aldo suppression test, or what would you do next?
I think I would go ahead with it, and I'll use the term aldosterone suppression test here. Based on our institution, there are certain tests that we would do, not doing the 24-hour or a loading test, but I think I wouldn't. It would be, within each individual patient, it would be after having a discussion with a gentleman that's had surgeries before, that's had other medical issues, whether they would be a candidate for surgery. And if they were, then certainly. I think one of the things that comes up on the treatment side that we often don't talk about that I found is that when a patient's on this many medications and you are advocating a certain diagnosis, you're essentially framing their medication list with one medication as a top priority and everything else as secondary to that medication. And you're not the only person who's ever going to see this patient. This patient will be seen by other specialists. This patient will be seen in the emergency department. And I think it's one of the really important reasons to do a confirmatory test or a suppression test of some sort is to put the primary aldosteronism on the map so that other people, including the patient and other providers, know that that is the central medication that's there for their blood pressure, that's there for their cardiovascular disease, and that stopping that medication in the future is probably the most detrimental for the patient's overall care. Because if you start going up on a medication like an MRA for a patient like this, and then they have developed some complication due to that, plus a combination of another medicine, it's my experience that the first medicine to go is the one that most of the providers are the least familiar with. And in this case, that would overwhelmingly be the MRA. And so I think there are other reasons to do the confirmatory test for the patient's long-term care besides their blood pressure and cardiovascular.
Okay, but let's just say that this patient might have a chance for curative surgery, and you were thinking in that direction and the patient was open to having surgery.
Yes.
Would you
I would.
still do a suppression test, Jordy?
So I actually, at our institution, in patients like this, where we have really decent, very good evidence that this person likely has, or they've got biochemical evidence of primary aldosteronism and a very good history for it, we actually don't do confirmatory testing. We proceed, if they're a surgical candidate or interested in pursuing surgery, we proceed straight to adrenal vein sampling. We will do a CT scan as well, just to ensure we don't miss an adrenal adenocarcinoma, which can happen in a small proportion of these patients and would be horrible to miss. But we always do adrenal vein sampling regardless of the CT results, since we've had patients who've lateralized to the opposite side of an adenoma, or who don't have an adenoma but still lateralize. Don't have a visible adenoma, it's likely a microadenoma.
Anand, do you want to comment on this?
So I'm gonna have to disagree with somebody since we have every answer here, so I feel better now. Okay, so I would not have done anything for this patient after the first. I think this patient had primary aldosteronism on the first slide. Resistant hypertension, suppressed renin, hypokalemia, aldo of 12 on an MR antagonist. I would not have repleted potassium. I would have said they have primary aldosteronism. I would have wrote it in the chart. I would have put it all over the place, confirmed. I don't think there's no value in doing an aldosterone suppression test. You don't need to confirm the diagnosis. You can claim it and put it in the chart. The only risk of doing it, which is a big one, is that the value may come back below what you used to confirm, which will then confound problems. I see this multiple times a week, and in case it wasn't clear from my presentation, I'm actually advocating that the entire process of confirming this diagnosis is overutilized. There's very few indications to ever run an aldosterone suppression test. If you suspect somebody has primary aldosteronism based on the clinical history, the suppressed renin, and any aldo that's inappropriate in that context, doing an aldosterone suppression test in addition to that is not validated at confirming the diagnosis and risks making you second guess or erroneously exclude the diagnosis you already made. So I think in this condition, where there's a gigantic bottleneck in even getting people to test, adding a second layer of unvalidated testing that can undo what has already been done is a giant problem. And the more people move away from aldosterone suppression testing, I think the better patients will be. So for this patient, diagnose primary aldo, decide you want to do ABS or not. If you're not sure they have primary aldo, put them on an MR antagonist. If you're sure they have primary aldosteronism, at minimum, they're on an MR antagonist. And so as quickly as possible, move them to a targeted approach.
So
I
one
can
comment,
expound on that, but that's my brief.
Yeah. So this patient already has one sort of confirmatory test. He had suppressed renin on lisinopril with elevated aldo. So I always I will start with an ACE inhibitor, ARB, and send my aldo and renin test while on that medicine. And if their renin is suppressed while on that medicine, I mean, that's even more suggestive.
But just Matt, just to say that more explicitly, what you said, he is doing an ACE inhibitor suppression test,
Yes.
which almost every patient, at least in the United States, with primary aldo is already on an ACE or an ARB. So they're already conducting one of two aldosterone suppression tests. Their aldosterone should be low and their renin should be high on an ACE and ARB. It's not. In addition, this patient was hypokalemic, which typically would suppress your aldosterone production in normal physiology. So there's really no need to load this patient with salt or use institutional resources to place an IV and have a nurse run a saline infusion or fludrocortisone suppression. This patient has primary aldosteronism, and you know, the quicker you make that diagnosis and move to the next step, the less likely you will get distracted or interrupted in the middle.
Do you think that lisinopril is helping this patient at all? Is he responding with a suppressed renin? Is his blood pressure even responding to this? This is a question that came up in the chat.
So in theory, ACEs and ARBs either inhibit the production of angiotensin II or block its action. And in theory, patients with primary aldosteronism have very little or zero circulating angiotensin II. So I would not say it's not helping at all, but its dominant effect is a little bit neutered by the pathophysiology at play. That being said, there's angiotensin II locally in tissues, and some people may have different sensitivity. So I think the use of these medications is so common that 80% of the people you see are already on it. Do I think they're playing a big role? Probably not.
We have a few questions coming in about, you know, the issue of AVS. One is it reasonable to use the serial approach given how invasive AVS, especially given how prevalent hypertension is? And then a similar question or related question is, should we also lower thresholds on the biochemical screen for surgery, you know, if we're missing possible cases?
Who's going to take that? Vivek, you're unmuted already.
Yeah, no, Steve, can you repeat the first part of the question? I'm sorry.
Absolutely. One listener wanted to know, is a serial approach, you know, primary and secondary testing, is it reasonable given how invasive AVS testing it is because hypertension itself is so prevalent? And then just the question about what to do with the thresholds for deciding on surgery or not.
I'll tackle the first one. I think it's on individual discussion, personalized approach with this patient. This patient's had hypertension for 40 years, and maybe at elevated cardiovascular risk, or is at elevated cardiovascular risk. If they are willing to undergo a surgery, then I think I would advocate for doing an adrenal vein sampling. The downside of doing adrenal vein sampling is you have to be at a center that has it, because things like, you know, newer imaging studies are not necessarily available and or validated. But I think I would definitely bring it up to the patient. I would be expectant that they may say no. I would be expectant that they may say, I'll redose my MRA, and we can try to get better blood pressure control that way. Using the caveat that I mentioned earlier about not using spironolactone in an older gentleman. But I would definitely bring it up as an option. The second question about thresholds for the actual lateralization, I'll leave to other folks on the call.
Was it thresholds for lateralization or thresholds for the ARR? I didn't see the question.
And I think they go hand in hand, Jordy, in some sense, right? So the higher the more severe the PA, the higher the odds of having lateralized PA. So you can kind of merge the two questions, and this might take us to, okay, how do you approach suppression and send patient to AVS? Is it based on renin suppression alone, or do you do more than that?
We tend to use our clinical judgment for sending them for AVS referral. So as long as their renin is suppressed and their aldosterone is in a range that, based on what their antihypertensive medications are, suggests to us that it would likely be elevated if we were to hold some medications and we use our judgment. We tend to refer with different thresholds than what's generally used. We don't necessarily require the aldosterone to be markedly elevated. We just require the renin to be suppressed. In terms of the lateralization thresholds, I wouldn't feel comfortable referring someone for surgery whose lateralization index was less than 4. I think that we've seen too many people that have had either borderline levels or that have had adrenal vein sampling done by centers that are not quite as experienced at doing it, and maybe the thresholds aren't quite as interpretable, where they didn't end up benefiting from surgery. That I just think it's a lot to do where you're referring somebody for a surgery that may not benefit them. So that's been our approach is a lateralization index of 4 is the minimum that we'll refer for surgery.
And this brings up the whole idea of, do we need any thresholds for anything, or do we need just a renin in case we consider medical treatment that's sufficient to offer an MRA? If we want to consider surgery, then what is the algorithm that comes below? So I stopped sharing because I know Anand has a tentative algorithm he might want to go, at least his approach, he might want to share with us.
And as he's bringing that up, there are a few questions about, are there data for outcomes with regard to medical therapy versus surgery among patients who do versus do or don't reach traditional cutoffs? Does finerenone, is this effective in PA? So sort of what do we do as we go down the treatment algorithm? There's also a related question to try to get these in. You know, if you have an aldo renin ratio that's positive, but then your suppression test is negative, what to do then? So that's sort of two different branches.
I would also add Dr. Funder made a comment, and I think someone was asking about an approach that he recommended, and he commented saying, why not screen everybody, put them on 25 or some dose of spironolactone or an MRA and see if they have a blood pressure drop, and then use that as a triage. And I think someone else was asking the question of a serial approach. I interpreted that to suggest something similar to this, which I think there's so many right ways to do it that are all better than the current approach, which effectively is that approximately 0% of the people who need to be tested are tested, and how to scale this problem beyond kind of large tertiary care academic medical centers is going to need creative and localized thinking like that. Like, you know, empiric use of mineralocorticoid receptor antagonists, even without testing, is probably better than what we're doing now, which is neither testing nor treating adequately. So if I can share a diagnostic algorithm, but I do it with the context that there's many right ways to do this. So this is an approach that I use where I practice, but I think there's a lot of other reasonable ways like the Funder approach and others that are suggested. So to begin with, who should be tested for primary aldosteronism? I think Adina already mentioned the high-risk groups: severe or resistant hypertension, hypertension with hypokalemia, or an adrenal mass. This has already been advocated by guidelines for decades. And as you saw, rather than 100% of these individuals, it's close to 2-3%. There's ongoing discussion now about expanding this to more people with hypertension, even all people with hypertension. There's many smart people proposing this and guideline committees racking their brains on this. I would say at minimum, you should focus on those in blue. And if you have the bandwidth to go beyond that, that's extra credit and would be great. So all of these patients should be tested. You don't need to account for the time of the day. You do not need to change medications, as has been discussed. If you need to repeat the testing, you can. But we're doing such a terrible job that you should not miss your opportunity to do this right then and there when the patient is with you in clinic. I would personally say, depending on where you practice, this may be more or less relevant. You should know the assays you're working with, as I showed you, whether you're dealing with immunoassay or mass spec, whether you're using renin activity or renin concentration. That can influence how you interpret things, but I'll try to be agnostic of assay because I know not all clinicians can be up to date on this at all times. So the first question is the renin low or suppressed, right? You're looking for renin and angiotensin II independent aldosterone production. Again, there's very kind of loose guidelines on what this means, but to me, this is a renin activity well below 1 nanogram per milliliter per hour, or renin concentration below 10 milliunits per liter, really the lower it is, the higher the confidence you can have. And you do this testing regardless of medications, but if the renin is not suppressed, really that's when you start thinking about whether the medications could have influenced your result. And the two dominant culprits are mineralocorticoid receptor antagonists and ENaC inhibitors, amiloride, triamterene. These medications treat the pathway of aldosterone MR action and can induce volume contraction and an escape of renin. So if your patient is on these medications, this is when you consider a washout for 1, 2, 3, maybe up to 4 weeks to see the renin go down. It's much less common in true primary aldo that ACE inhibitors, ARBs, diuretics will dramatically raise renin and steer you away from the diagnosis, a false negative, but it can happen. And so if your pretest probability is high, you can consider washing those out as well. Once you've established a suppressed renin, you can look to the aldosterone level. If it's over 15, this is primary aldosteronism. And in my opinion, these patients need no further investigation. What you have to now determine is how you want to treat this patient, which will factor into many discussions, but at minimum, they warrant mineralocorticoid receptor antagonist therapy synergized with dietary sodium restriction. And depending on the case, you can decide whether you want to localize the disease to see if they're amenable for surgical adrenalectomy. On the flip side, if the renin is suppressed and the aldosterone level is very low, particularly with an immunoassay below 5 nanograms per deciliter, the likelihood that this is a clinically relevant primary aldosteronism becomes unlikely, except the caveat is if your patient was concomitantly hypokalemic, this can drag the aldosterone level very low. And so that's a reason to replete the potassium and repeat testing. And what I would say is even if you get to a point where you say this is not primary aldosteronism, it is at minimum low renin hypertension, which responds really well to an MR antagonist. So you'll see here, all pathways lead to at minimum a mineralocorticoid receptor antagonist once you start down this road. For everything else, that is a high-risk patient with a suppressed renin, virtually any other aldosterone production, your mindset should be it's primary aldosteronism until proven otherwise. Okay, we're doing a terrible job diagnosing this. What you're saying at this point is, I know that low renin hypertension manifests as a continuum of primary aldosteronism pathophysiology. This patient is somewhere on that continuum. At minimum, they will respond for medical therapy. And on a case-by-case basis, you may want to localize this disease to see if they're amenable to a surgical cure. Should you use an aldosterone suppression test? Okay, so I just want to emphasize that these are not validated to confirm or exclude the diagnosis. So if you do it for academic reasons and it makes you feel better, more confident, fine, at least be honest with yourself. Sometimes it can help you prognosticate the probability of lateralizing. So depending on what resources you have, if that helps you prognosticate the value of AVS, you can use it. But if you do the aldosterone suppression test, just beware that they are not validated at excluding the diagnosis. So in my opinion, this is what renders them essentially optional. Because if you're not going to use it to exclude the possibility of the diagnosis, you're doing it for academic reasons. And finally, depending on the patient in front of you, your resources, and your healthcare setting, do you need to clinch a biochemical diagnosis? Personally, I think there's value in making a biochemical diagnosis, but there's always reasons why that may not be possible or reasonable. So if your patient has a low renin, you can empirically treat with an MR antagonist. That's better than doing nothing. And you could even argue liberalizing MR antagonists for many more patients with hypertension, particularly those with resistant hypertension or hypertension with hypokalemia. It's certainly better than nothing. And so this is, you don't have to buy into this entire algorithm because like I said, there is no gold standard to validate and calibrate all of this. But this is a general framework that will hopefully either help you diagnose more primary aldosteronism or at least liberalize the use of MR antagonists to get to more patients who need these medications.
All right, thank you all. I think we've addressed a lot of questions that were in the chat, and if they weren't addressed verbally, we've tried to answer online as well. Some of this may carry over into Twitter or something else, and hopefully it will answer further questions. But I'd like to close out and thank Adina and Anand and our panelists, Dr. Cohen, Dr. Bhalla. Thank you for joining today, and we hope that this will increase the screening and treatment for these patients with resistant hypertension. So again, I'd like to thank everyone for participating and close out. Thank you very much.
Thanks for having us. Bye, everyone.
Thank you.